doing AI from Seoul. And
I
then
see.
he had to go back to the army in Korea.
Oh,
They had this
yeah,
2-year,
yeah,
right? Yeah. So, but he was a very good fellow.
yeah.
So
It's a mandatory military service.
yeah. All right. So I think let's see how many people we have now. 11. I think we could start. I think in the interest of time. So today at our forum, AI forum, we have Dr. Sung from UCLA. He's an associate professor in the interdepartmental program in physics and biology and medicine at UCLA. And we'll be talking today. If you could put your first slide so we can see the title.
Oh, sure.
Sorry, because So we'll be talking today about the deep learning applied to MR images in personalized prostate cancer care, imaging deep learning applications. So Dr. Sung, please continue.
All right, thank you. Thank you for the introduction. Can you guys hear me well?
Yeah.
Okay, sounds good. Then I'll get started. So today we'll be talking about some of the applications using a deep learning for a personalized prostate cancer care. So as you guys may know, the prostate cancer is actually one of the biggest problems for men. And if you look at the incidence, almost 15% of the men will be diagnosed with prostate cancer in their lifetime. So it is actually a big deal. And if you look at the number and also the number of people who die from the prostate cancer, that's not small. So it is a very big problem, particularly related to cancer diagnosis. So if you look at the 2021 NCCN guideline for the prostate cancer diagnosis and treatment pathway, it actually starts with the initial risk assessment based on the rapid testing, such as family history and other biomarker testing, etc. And then once you have a higher risk, it is recommended to have a imaging followed by biopsy. And then once you have a biopsy shows a significant risk factors, then it's recommending to have a germline testing. And then after the risk stratification, you have a treatment for the prostate cancer. So more in particular, if you look at the imaging specific pathway for a early detection, the first starts with the PSA. PSA is a prostate specific antigen. And then it's actually very popular for cancer screening when a person becomes between 45 and 75 years. And if the PSA is higher at certain level, here 3, then it's actually recommended to have a biopsy. So before having a MPMRI, followed by the biopsy, the treatment options will be guided. But having an MPMRI, particularly the pre-biopsy, has changed a lot in the biopsy guidance. Particularly gives the who's going to get the biopsy, and also a targeted biopsy, meaning where do we put the needles on it, so that we can improve the detection of the clinically significant cancer. And even further, before the treatment, the MPMRI or MRI is used, particularly for the active surveillance, meaning the active monitoring more regular fashion, or a surgical planning, so that we can determine the surgical margin and or other planning for the surgery as well. And also even after the treatment, the MPMRI is important because it is actually used for a post-treatment monitoring option. So that being said, the multiparametric MRI, or we'll be using it as, or call it as an MPMRI, it is actually continuing to gain clinical acceptance as preferred imaging technique for non-invasive detection of prostate cancer. So what is MPMRI? MPMRI consists of typically have of 3 major components. One is called a T2-weighted imaging. It is acquired by 2D turbospin echo sequence or 3D space sequence. And also the second component is called diffusion-weighted imaging. It's acquired by single-shot EPI sequence. And then the third component is called a dynamic contrast lens MRI, or DC MRI. And generally speaking, this one is the T2 weighted imaging is more related to a anatomical or more structural information. And also the DWI or diffusion weighted imaging is related to the cell density. And then DC MRI or dynamic contrast-enhanced MRI is giving you more the tissue perfusion information. So by combining all three information together, the major question that we're trying to address is to identify where is the tumor or tumor detection and localization problem, or what types of tumor, meaning the tumor characterization problem. And in general, the clinical interpretation of this MPMRI is done by so-called a PIRET system or prostate imaging reporting and data system. And that's the standardized interpretation protocol for radiologists, trying to make a consistent interpretation across different institutions and readers. So the way that the PIRET system works is it gives more kind of suspicious level from 1 to 5, 5 being high, 1 being low, and giving a chances or likelihood of having a clinically significant cancer. So depending on the location of the lesion, if you look at the left figure, you start with the peripheral zone. So if the lesion locates in the peripheral zone, then you look at the diffusion weighted imaging, and then try to assess the likelihood of having a clinically significant cancer. And if it's a 3, then you look at the DCE, whether the DCE curve is negative or positive, and then you will have the final score, either PIRET 3 or PIRET 4. If the lesion is located in the transition zone, in the other hand, then we look at the T2 weighted imaging instead of DWI, and then we give a score from 1 to 5. And if the score is 2 or 3, then we look at the diffusion weighted imaging, and then based on the diffusion weighted imaging, we determine whether the PIRES is 2, 3, or 4. So those are kind of very manual processing, and there's a lot of subjective scoring included, but try to make it more standardized so that, as I said, the readers to be consistent across different institutions and within the institutions as well. So if you have a PIRET score 1 or 2, then it's defined as an MRI negative. So there's no outstanding lesion found. And based on a PIRET 1 or 2, what's going to happen is if the risk is low, meaning if the either PSA score is low, or there's no family history and other demographic information is showing a low possibility, then it's recommended to have a so-called active monitoring. Or if the risk is high, then it is recommended to perform a systematic biopsy. Systematic biopsy is basically, without knowing any targets, you actually apply a template-based biopsy, sometimes 12 or 24 locations, and then getting the tissue samples out for the biopsy samples. If the PIRET is 3, then it becomes a MRI positive, but still it's not as strong as PIRET 4 or 5. So depending on the risk factors, so still if it's low risk, then it is recommended to go through the active monitoring. But if the risk is high, then it's recommended to have a MR targeted plus systematic biopsy. So in other words, MRI will identify the lesion based on a PIRET 3 score, and then there will be also a combination of a systematic biopsy, just in case we miss anything. If the PIRET is 4 or 5 and the patient is biopsy naive, then it's recommended to have MR targeted plus systematic biopsy. And if it's a repeated biopsy, then it's recommended to have a MR targeted biopsy. So depending on PIRET scores, there are different guidelines and pathway for the patient care and treatment. So there are actually two very recent studies, big studies in terms of impact of having prostate MRI before biopsy, whether it actually helps or not. So the comparison is the one cohort has an MRI before biopsy, the other cohort doesn't have an MRI, and then they actually evaluated whether there's any benefits or impact included when there is an MRI before biopsy. And those two studies found that when you have an MRI before biopsy, it's going to reduce the number of patients being biopsied, and it's going to reduce the diagnosis of insignificant prostate cancer. And also it's going to reduce the number of biopsy cores per patient. So it's actually pretty obvious that there is a clear benefit of having an MRI before biopsy. And as I said, those two are the major impact papers and published it very recently. And then it basically creates more demands on imaging studies before prostate biopsy. But there are some complications included. I mean, the study by itself, it's a nice study design, and then it's a large cohort trying to look at the comparison between and with and without NPMRI. But if you look at the NPMRI and biopsy results, which is top two, it actually included a lot of value chains. So in other words, the NPMRI has to be interpreted by PIRES, and then PIRES, based on PIRES, as we explained before, there are a lot of multiple biopsy strategies included. And then you have to have a biopsy. It could be targeted biopsy, systematic biopsy, etc. And then also biopsy has to be interpreted by pathologists. And then that biopsy results will be coming out as the final histopathology. But the study is typically comparing the PIRES versus biopsy results. So we are actually missing components in here. And also it is much more complex processes than just simple comparison. Particularly, we're interested in more between the NPMRI and PIRES, particularly related to is patient preparation is done well, acquisition protocol, what is the acquisition protocol, and what is image analysis and modeling, and are we based on the experienced radiologists and reporting and documentation are adequate or not. And in general, as I said before, in PIRES interpretation, it's actually very manual, subjective, and experience-based. So therefore, it actually included a higher inter-reader variability and also high inter-scanner, inter-subject variability as well. So that being said, it's actually very important to have a consistent image quality and also imaging to be quantitative so that it can be more independent of the image quality as well. And in parallel, the artificial intelligence is a big deal and a great tool to improve in many different aspects, particularly if you want to combine the imaging with biomarkers, clinical and demographic information. The AI is actually a great tool to do so, or a great tool to enable to do so. So that being said, combining the image quality, consistent image quality, quantitative imaging with artificial intelligence is a key trend to go from population-based diagnosis to precision-based diagnosis. And that way, it's going to increase the detection of patients needing active treatment. And also, it's going to improve the precision in index tumor rate and volume determination as well. So that's, to me, the main theme at the moment for a prostate cancer diagnosis, particularly to achieve a precision and personalized cancer care. Okay, so as I said, the deep learning artificial intelligence, it came out a long time ago, and it's not a new concept at all. But if you look at the timeline, the deep learning came out around 2010, and it becomes much more popular because it actually beats a lot of different existing methods, and then it performs really well compared to other baseline methods. So that created huge impact to many different fields, and the healthcare is also another big market that AI has been impacted a lot. And if you look at the market is expected to reach almost $36 billion by 2025. And if you look at it, the machine learning technology is the major whole share of the AI in healthcare market. So obviously the AI is becoming more and more important, and machine learning is actually becoming much more important as well. So what is machine learning? I mean, machine learning, there are multiple different definitions included, but the most important aspect is it gives the computers the ability to learn a model based on a data or data pattern. So instead of using a explicit mathematical modeling, we're actually giving a chance that the machine can understand the trend or the way to achieve the results based on a training. So that's the high level understanding of the machine learning. And there are a couple of different tests in medical imaging. First one is called a classification. So classification could include the image or object classification or the lesion classification, whether the lesion is belonging to clinically significant cancer versus not, or whether the image included something or not is the classification test. Another thing is actually detection. So you can detect the organ or landmark or lesion, or you can do the segmentation. So it can be used as a organ and substructure segmentation or the lesion segmentation. Another application is the registration between modality, different imaging components, different time frames. Those are the used application for deep learning. And then the other thing could include image enhancement, reconstruction, image generation, and the combining imaging data with reports, etc. So if you look at the machine learning, deep learning, as I said before, the data is important, and annotation, and those components are the key for the developing a deep learning. So if you look at the non-medical imaging or healthcare application, there are a couple of very popular imaging data sets, including NIST data, CFAR10, and ImageNet data sets. However, it's not trivial to achieve or build a medical imaging database with higher number of images and accurate labeling. So that's a big challenge. And at UCLA in radiology department, we've been actually investigated a lot in terms of generating the labeled MPMRI data, particularly for the patients who are undergoing radical prostatectomy. Because when the patient going through the radical prostatectomy, we have a situation that we can acquire the imaging before surgery, and after surgery, we have a whole mount histopathology that gives a ground truth information of the tumor location and the tumor grading. So for example, if you look at the imaging before surgery, we have a multiparametric MRI, including T2, DWI, and DCMRI. And the interpretation is based on it's recorded on a radiology report. Same thing after the surgery, we have whole mount histopathology, and then the pathology report will be recorded to show a interpretation of the histology information. That way, we can actually compare head-to-head before surgery imaging data finding, and also after surgery pathology finding. We can compare each other. And we actually started since 2010. So we accumulated almost more than 1,000 cases so far. So that being said, how do we collect those information? This is an example of the UCLA multidisciplinary team meeting. This happens monthly. We have radiologists, urologists, and pathologists together. And then basically, if you look at the screen, the left side is basically the radiology interpretation without knowing the pathology information. So that's done before surgery. And then the right side is actually the pathology information without knowing the radiology interpretation that happened after the surgery. And at the meeting, we sit down together and then compare each other's findings together. And then that way we can actually understand what is the true positive, meaning MRI findings is equals to the pathology finding, or false positive, meaning MRI says there's some findings, but then there's no findings in pathology, or false negatives as well. So that's a great process, and we do that monthly basis and then accumulate the cases so far since 2010. Okay, so this is an example of so-called integrated diagnostics. So in other words, you see the full radiology report, full pathology report, and then anything that matches together are highlighted. And then if it's not, then they're considered to be false positive, false negative cases too. So what does that mean? Here's a kind of typical example. We can actually create, as I said before, we can create the radiology pathology correlation. So MRI, in this case, we have 3 different lesions. And then histopathology, we have 2 different lesions. And then if you look at 1 and 2, those are considered to be a true positive, because if you look at histopathology, there is a 1 giant lesion in there. So that's, to me, to us, it's connected as a true positive lesions. And then also there's a 3Y on MRI finding, and then there's nothing on histopathology. So that's considered to be a false positive lesion. And also in the histopathology, if we find something, but then there's nothing in MRI, then it's going to be a false negative lesion. So based on this strategy, we are actually annotating everything, true positive, false negative. And then it is well matched between the MRI and histopathology in terms of location of the sites. And then we have organized data sets so far. Okay. And based on that, the first test that we did is so-called AI-enabled prostate cancer detection. And this is a typical deep learning based the cancer detection algorithm. The common challenges for this is to utilize the multiparametric MRI. So in other words, the multiparametric MRI included T2 weighted imaging, diffusion weighted imaging, and perfusion imaging. And the lesion locations and lesion appearances could be quite different each other, meaning sometimes it shows well on T2 weighted imaging, but not showing well in DWI, or the lesion shape or the size of the lesion could be different for different imaging components. So to account for it and to overcome the challenge, we actually developed a method called a focal net, which actually is based on a mutual finding loss and a ordinal encoding. So the mutual finding loss is basically automatically looking at the weights in between the multiparametric MRI. So it actually selects or emphasizes more on one imaging component than the other based on the situation. And that way we can actually systematically combine all the multiparametric imaging information together. And also in terms of cancer classification, we actually utilize the so-called ordinal encoding. What it does is basically when you have a multi-class classification, the distance between different classes will be somewhat equal when you use a one-hot encoding. But in cancer classification, the distance has to be somewhat weighted to each other. So that's why we're using a ordinal encoding instead of one-hot encoding. So by combining those two, as I said, we constructed so-called a focal net. And then we showed improved the cancer detection and classification performance. So here's an example of the automatic cancer detection using deep learning. The bottom row is a so-called histology information as a ground truth. And then based on this ground truth, we annotated a lesion location and lesion boundary. And also each lesion was grouped as a different Gleason grade groups. And based on this training, this is the testing results. The orange axis are based on our automatic deep learning cancer detection. And as you can see, it actually matches really well each other. And we also investigated the FROC curve based on different deep learning method compared with our proposed method. And as you can see, the UNet and DeepLab are performing okay, but our proposed method based on a mutual finding loss works better than the standard baseline deep learning approaches. And also, if you compare with the radiologists, the performance of the AI-based model was actually quite comparable to each other. And also, based on that, we actually conducted a independent testing compared with the radiologists. So both radiologists and FocalNet never seen the testing sets, and we prospectively compared the performance head-to-head, which one actually ended up detecting the cancer lesions better. And the radiologists, we utilized 4 different radiologists. 2 of them are highly experienced, and then 2 of them are medium level experienced. And then they're given all this prostate MRI data, 127. And then based on the imaging data, they give likelihood of having a prostate cancer lesions. And then we compare the performance together, and then ended up, it's actually quite comparable to each other. I mean, it is somewhat expected that the different radiologists are producing quite different results. Some are highly sensitive, some of them could be highly specific. But what matters is actually the FocalNet, which is our AI-based detection algorithm, can actually achieve a quite comparable performance compared to other radiologists. So in summary, for the cancer detection, we designed the improved CNN network called a FocalNet. It's based on a mutual finding loss and also ordinary encoding for the cancer classification. And for the lesion with the Gleason score 3+4, we have achieved almost 95% or higher detection sensitivity at the cost of 1 false positive detection per patient. And that was awarded at the 2019 at IEEE ISBI. And also, as I said, the head-to-head comparison between FocalNet and radiologists, we evaluated using 126 patients. It actually shows a very similar detection performance under the high specificity and high sensitivity conditions. So that's the detection problem. Another example is actually prostate segmentation. So as you see in the PI-RES interpretation, the different identification of different prostate zones is very important. And segmentation of prostate gland, peripheral zone, and transition zone can enhance the automatic CAD systems of the prostate cancer detection and characterization as well. So that's why it's the prostate segmentation is kind of key foundation to enable the automatic deep learning based cancer detection. And the typical way to do is you feed in multiple T2-weighted imaging, and then the UNet is actually one of the popular methods to do. And then the results came out as a prostate zonal segmentation. That's the typical setup. And as I said, most likely it's going to be a volumetric imaging as an input, and then the prostate volumetric segmentation will be an output as well. So in recent study, we actually developed a little bit or improved the prostate segmentation algorithm using a spatial attention and also the Bayesian deep learning network to provide the uncertainty estimation after the segmentation results. So spatial attention is giving a more accurate localization of the information, and that gives improved performance. And also we utilize the Bayesian approach to be able to estimate the uncertainty after the segmentation is done. And if you look at the right side, those are the example of the output, prostate zonal segmentation and uncertainty estimation. And here's an example and the comparison between the conventional UNet and the proposed method. UNet typically works fine, but some cases UNet has a little bit of problems in the the zonal segmentation, whereas our proposed method typically doesn't have too much problem regarding that. And if you look at the volumetric segmentation, it actually gives a very good integration of the zonal segmentation results as well. And this is a comparison between our proposed method versus the manual segmentation. You see the results came out really well, and automatically the zonal segmentation results were very satisfactory. And also we conducted the kind of inter-reader variation issues, because if you look at the base end and the apex end, sometimes different readers are giving a different results. And if you look at the comparison between a deep learning based segmentation versus the expert based segmentation, those are highly comparable each other. So that was quite promising. So based on that, we actually conducted a large continuous cohort evaluation. So this is based on more than 3,000 cases. And then instead of measuring a dice coefficient, which requires a ground truth annotation, we actually conducted a so-called a reader study. So the two readers are recruited, and then each reader was assessing the quality of the segmentation. And then if you look at it, almost 97, 98% of the cases, two readers both reported that the segmentation results are highly acceptable. So if you look at the whole gland segmentation and overall whole prostate, almost 99, 98% of the cases are either acceptable or excellent quality. Only a few cases out of 3,000 cases, we were observing that it is not acceptable. And if you look at the different location of the prostate, we saw a little bit more problem on the base locations. But even at the base, almost 96, 97% of the cases are either acceptable or satisfactory. So that being said, as a summary for the prostate segmentation, we actually proposed a novel deep learning method in combination of spatial attention and Bayesian uncertainty estimation. And the performance, we also conducted the internal and external testing sets, and then the difference was subtle. And afterwards, we also conducted more than 3,000 testing cases. And then the almost 96% of the testing cases achieved either acceptable or excellent automatic segmentation results. And then if you look at the dice coefficient score, it was more than 93 percentile, which is much better than other existing methods. And we also did some the volume comparison based on a manual volume estimation and the automatic. Almost 96% of the evaluation cases achieved within 95% limits of agreement. So that being said, potentially this automatic segmentation method can replace the volume estimation or prostate volume estimation as well. So that's the summary. As I said, we actually achieved different ways to improve the cancer detection, cancer classification, and tumor segmentation, and prostate segmentation. And even further, we also did conduct the comparison, head-to-head comparison between AI versus human, and also with the large cohort evaluation on the prostate segmentation. So that's so far our achievement in the prostate AI project. Moving forward, we've been actually investigated on a texture-based deep learning method for the cancer classification, and also a radiomics model for predicting prostate biopsy results, and also super resolution MRI and the lymph node invasion of with prostate cancer, and also integrating AI with the imaging and genomic information together. Even further, that's the prostate-related application. We've been actually doing a placenta imaging quite a while. I'm not going to cover too much details on the placenta imaging, but the placenta is actually quite interesting organ because it changes over time. And a lot of people speculated that the earlier placenta functions and anatomical developments matters entire pregnancy. And even after the pregnancy, the outcomes on the fetus and the maternal side will also be impacted a lot. So there's a huge interest going on the non-invasive, a functional assessment of placenta. And that's why the Human Placenta Project came out from NIH. And as part of the awardees, we've been actually developing a new imaging method and also the new machine learning method to be able to predict the ischemic placenta disease and also predict the gestational diabetes as well. And also we've been investigating the breast MRI or breast cancer applications. So one of the differences between prostate and breast, you need to actually also have a more accurate segmentation and also the so-called a background parenchymal enhancement assessment. So that's something that we're currently ongoing and try to find a difference between a risk factors on breast cancer with the germline mutation, woman with the germline mutations as well. So those are the kind of ongoing project. A few weeks ago, ARRS in radiology, there are a couple of very interesting discussion went on. So I just want to kind of share some of the thoughts or the discussions together. Particularly, they had a couple questions regarding how will AI change prostate MRI? That was the theme of the discussion. And there are a couple of questions. So I'm going to go over some of the questions and then I'm going to share my thoughts. And potentially after the talk, maybe in case anyone interested in discussing more, we can do that afterwards as well. So the first question was actually, how is diagnostic performance of prostate AI affected by image quality? That was the first question at the ARS radiology chat. And then, this is somewhat consistent with what I was mentioning before. The MRI is highly heterogeneous. I mean, it is depending on the imaging protocols and also the vendors are very different. So it is very important to standardize the patient preparation, data acquisition strategy, imaging analysis. If you don't consider that carefully, sometimes your AI development will be garbage in, garbage out type thing. So you have to be really careful and understanding the sources of bias and variance. Otherwise, potentially something is working in a very controlled environment, may not work for outside. So that's the problem. I mean, for example, at UCLA, we have a lot of MRI scanners, more than 20 MRI scanners available. And then every day it keeps working and acquiring data. So if you look at it, it's a huge entity, even just one institution. And then there are a lot of variance in the manufacturers and in models and field strength, etc. So it is a huge problem, and the quality control is a bigger or big problem per se. And not only that, it is geographically spread it out. So not only UCLA, Cedars, and other hospitals as well, we're expanding the imaging centers. It's not going to be just a single Westwood only location. We're actually expanding out. The challenge is the MR technologies are different. Everyone is spread it out. So having a consistent imaging protocols and patient preps, the QC, those are highly, highly challenging, particularly in LA, from Santa Clarita to maybe Palos Verdes. That takes like 2 hours to travel. So it's really hard, challenge to be able to make the consistent image quality protocols, etc. So for us, we have weekly MRI acquisition protocol meeting. So that being said, we have a radiologist included and MRI technologist included, and also, of course, MRI scientists included. And as a QC process, we actually go over some of the imaging artifact cases with the imaging artifact and standardize or adjust and refine the imaging protocol on a weekly basis. And that way we can actually achieve more consistent image quality, more up-to-date the data acquisition aspect as well, and also understanding the current challenges of the imaging artifact as well. So that's our attempt. And as I said, to answer the original question, it is highly important to understand the imaging and image quality in terms of developing AI methods. So second question was, is AI for prostate cancer detection on MRI ready for every patient? The answer is not yet, although there are a lot of methods developed, but it's not yet ready. Why? There are a couple of challenges, as I said, existing. Particularly, the problem is not well posed. So in other words, in non-medical field, image classification like cat versus dog, those are pretty sharp boundary. Cat is cat, dog is dog. But in a healthcare side, sometimes the boundary is very vague and it changes over time. For example, the definition of clinically significant cancer, it actually changes over time. And still there's a debate whether we have to include a 3+4 lesion if size is smaller, or should not include it if the size is not, or maybe entire 3+4 versus 4+3 discussion is ongoing. So the definition by itself, it is evolving over time. And if you consider a Gleason score or a Pirate score as a ground truth, all of them are actually manually done. The Gleason score is a subjective score, and there is a huge inter-reader variability. Same thing as Pirate scores. It actually includes a huge inter-reader variability. So those are very moving target, and that's why it actually makes very hard for AI to do something more of a meaningful way. And not only that, I think the interpretation and explainable AI is a key. And because sometimes if the AI is giving you a black box, it's not sometimes very easy to translate to the end user. The end user has to somewhat understand what's happening and also giving some confidence about the AI results. For example, in our segmentation problem, we actually developed the method to give an uncertainty estimation. So if the uncertainty is higher, that being said, the readers is not supposed to trust the results. That way it gives more confident process so that you can trust the results better. And that types of processing, giving more interpretable, explainable AI is the next step, but we're not really there yet. And in many cases, the validation is based on a single institution. And for example, pretty much all of our group's publication is based on UCLA data. But we are also interested in multi-institutional validation, but it takes much more time. So that's also another hurdles in the AI developments. And then that kind of like limits the ready for use of AI methods yet. Okay. And then the third question was, which aspect of diagnostic test performance will AI most improve? This is very personal, so anyone can have different opinions. In my opinion, in prostate MRI, there are huge potentials on negative MRI. So in other words, if the MRI or Pirate score is 1 or 2, there is huge decision making whether we should get a biopsy or not based on a simple risk category. And our recent publication is showing that the radiomics features are very different when MRI is negative, but biopsy is negative versus MRI negative, but positive biopsy. So in other words, MRI is negative, so the Pirate says 1 or 2, but the bottom case is actually there is a cancer somewhere. So if you look at the radiomic features, those are very different. And we were able to achieve a good classification on who needs to get a biopsy versus who doesn't need to get a biopsy if the MRI is negative results. And then we compared with the current process based on a PSA density, where we are able to achieve much better performance compared to the conventional approach. So hopefully that application could actually improve better in terms of deciding which patient needs to go through the biopsy versus not. Another application is actually Pirate 3 lesions. So if you look at the Pirate 3, there's a huge difference between the risk factors not getting a biopsy versus getting a biopsy. So recent publication also tells us that the PIRES 3 lesions, the current PIRES by itself has a very low specificity, but using a texture-based deep learning method, we were able to tell the differences between who or which lesion has a clinically significant cancer versus which lesion is not clinically significant cancer. And based on that, we were able to tell who needs to get biopsy or which lesion needs to be considered as a clinically significant cancer versus not. So that's, to me, one of the most exciting applications that the AI can help further than the PIRES interpretation. The last question that I want to cover is will AI eventually replace radiologist interpretations? This is a very interesting question. Particularly ARRS is a radiologist community, so this one was quite interesting question for them. About 5 years ago, Jeff Hinton, who's the father of CNN, he actually made a very interesting remark. He said, people should stop training radiologists now because it's completely obvious that in 5 years, deep learning is going to do better than radiologists. That's exactly what he said in 5 years ago. Actually, interestingly, that was exactly 5 years ago, but still we're developing a lot in AI and there are actually a long way to go. The main reason is the way that the radiologists work is much more complex than just simple process to be able to separate cat versus dog. And also there are a lot of the other components to be understood in terms of making a clinical decision. So to go back to the question, I would actually say, I don't think the AI will be replacing someone. It's more improving overall patient care. So the AI will be somewhat an assisting tool to be able to make the radiologist interpretation to be more effective or efficient. So that's going to be the future direction to my mind. So eventually it's going to actually make it more, maybe more improving aspect rather than replacing aspect. So in the future, so what do we see? I would actually say the human AI interaction, as I said before, instead of replacing it more as an assisting tool, the human AI interaction is a key important aspect for the future. And then integrating the models in the workflow is important. And also accessibility for non-developers will be very important aspect. And as I mentioned before, the interpretable and explainable AI is a key to be able to help the understanding of AI results. And also, as I said in the first question, the multi-institutional, multi-vendor validation is important. And the NIH quantitative imaging network and also RSNA quantitative imaging biomarker alliances, they've been actually working hard, make sure that we can achieve multi-institutional, multi-vendor validation aspect too. So that being said, that's pretty much covers what I think is important in the prostate AI and MRI. And I just want to thank my intra-departmental collaborations and also the funding and my students and the lab members as well. So thank you. Thank you for your attention.
Thank you very much. Beautiful lecture, very clear. We learned a lot today about new application in deep learning. We'll have questions now. We have 10 minutes. Maybe I'll start with some and then you guys think of some questions. So one thing, I noticed you presented FROC curves and we are not typically used to, like at least I'm not so used to FROC, I'm just used to ROC. Maybe you can comment on this. And and just like looking at these curves, I thought, like, I'm obviously not working in this field, but I thought like the biopsy is, that this is a pretty close to imaging, but somehow these ROCs are not that high. And it seemed to me like, I mean, not just yours, but like the physician. and like the imaging and what they can see. And it seems like they like 80% sensitivity and like few false positives per patient doesn't seem to me, as a naive kind of bystander looking at this, as a very efficient result. But this could be just the way the field is. So I don't know if you can comment on.
Yeah, so the first question is, what is FROC? FROC is a free ROC curve. So that being said, the x-axis is the false positive per patient or per case. So it's actually very popular metric for detection algorithm. So in other words, when you detect something, sometimes you're detecting more at the cost of false positive. So that's the FROC. And then how do you understand FROC? So the FROC typically goes up at the cost of false positive. So if you have a lot of false positive, but still you can achieve a good detection rate. That being said, I think it gives more opportunities for human AI interaction, because if you look at some of the examples of, I didn't really show the AI-based detection, some of the location of the AI detected lesion, it's actually pretty obvious that it's not a true lesion. I mean, in a human eye, it's very easy to tell because it could be part of the artifact or the boundary or something. So that's why I see it has a lot of promising performance, meaning we can clean up those false positives and then basically focusing on the harder to detect lesion based on AI. I think eventually it's going to improve the sensitivity and specificity as well. So that's FROC related. The second question, the sensitivity specificity, it is interesting. And generally speaking, the PIRES 4 and 5, which is obviously the MRI is showing a very outstanding lesion definition. They have really high sensitivity specificity, and the ROC curve is really high. Whereas there's a huge boundary called a PIRES 3 lesion, and this one is very cloudy. So a lot of institutions, they don't treat 3 as a positive lesion. A lot of institutions, they treat 3 as a positive lesion. So there is a huge debate in between, and that kind of tells low sensitivity specificity as well. And that's why I see the huge potential that the AI can help and maybe give an assisting tool to be improving overall.
So I had a question. I think this, I really enjoyed your presentation. Congratulations. It's very careful work, I can see. And it's an extension of Piotr's question, really. So when you looked at lesion detection using your algorithm, how much improvement in sensitivity and specificity did you see?
Yeah, I mean, so improvement compared to human or the baseline methods?
Compared to what the clinical standard is today.
Yeah, so that's a great question. I think in terms of the biopsy decision making, we see first, I don't really recall the exact number, but for example, if the MRI is negative, and then we ended up deciding which patient needs to go to the biopsy versus not, the typical MPV, negative positive value, predictive value, is around 90 something for the conventional, but then using AI, we could actually make it 98, 98, 99%. So that being said, we can reduce a lot in unnecessary biopsy. Another thing is actually PIRES 3 lesion. We saw like specificity is around 50%. Whereas in our case, we can improve the specificity about 80 or 85%. So that being said, we can also improve a lot in terms of who needs to go to biopsy or who doesn't need to go to biopsy. So that kind of tells us reducing huge numbers of unnecessary biopsy aspects.
Yes, so that's very helpful to know, because in the end, what we're trying to do is to make an impact on clinical care by adopting these novel algorithms. And the onus is going to be on us, right? For example, you're going to have to take this to a clinical trial to show that actually by reducing the number of biopsies and how you make care more efficient, that's eventually what it's going to take for adoption.
Yeah, I mean, I definitely agree, and that's something that I'm hoping to continue in terms of evaluation. As you see, in the beginning, I was mentioning about the precision trials and promise trial. Those are the big trials, multi-institutional trials showing, okay, we do NPMRI before biopsy and without NPMRI and performing the biopsy, and we show the improvement in patient care. And then they published it, and then entire landscape has changed since then. Same thing, I think we have a lot of publications in the technical validation, but in the end, what matters is there's got to be a huge trial, particularly multi-institutional trial, showing AI versus non, and then showing a clear patient care improvement. I think things will actually change very rapidly.
Any other questions here we have from the audience?
Can I ask a quick question? Sorry.
Sure.
Was there another one? Great lecture. I really enjoyed your presentation. Is there a way that, because I know that you have done the segmentation on the MRI images, is there a way you can combine the multiparametric MRI, like the different sequences, so that somehow you can delineate the area of interest?
Yeah, so I mean, there are multiple ways, right? I think the way that we like to do is actually applying a registration between NPMRI. So one of my postdocs is actually currently doing, because the key component is you need to do a prostate and zonal segmentation, and then the registration is much easier to do something. So right now, at the moment, we're trying to register each other between T2 ADC and the perfusion imaging together. But there will be different ways. Maybe you can actually train differently and then try to output in each imaging information differently. That's also one possibility. But in our case, we're trying to register together. And so-called another project that I didn't mention too much is a prostate atlas project. So we're actually trying to create more the template-based cancer detection and register everything together between a subject and also between imaging component. That's actually an ongoing project.
Okay, thank you.
Yes, I was also having this question, as Dr. Day mentioned, like when you detect the tumors in the prostate region, you consider the three sequences or three modalities together as a whole input to the network. However, like as you mentioned in the slides, that these imaging sequences carry like different information. It may find a tumor in one sequence, but not in other two, and it all depends. It also depends on the location of the tumors. So when you include these like findings in one network, how did you balance the decision making and like to balance the false negative, false positive, these like little details?
Yeah, I mean, that's a actually excellent question. That's why sometimes the lesion segmentation, when people reporting the dice coefficient of the lesion segmentation results, that's not easy to assess because the lesion appearance on T2, DWI, and DC may be different. So that's, to me, a little bit kind of, I don't know, it's an open question at the moment. But more importantly, the detection performance, whether we are detecting or not, it's based on histology. So no matter how it shows up in the NPMRI, if the histopathology says, or here's the lesion here and the boundary, that's the most important information. So we're trying to match that ground truth information. And then no matter how it shows in the NPMRI, it's a still open question, and how do we utilize it is also something that we're ongoing, somewhat an ongoing project. But that's an excellent question. you know, I think there are multiple ways to achieve it. We're trying to tackle one or two different ways. Yeah.
Thank you. So does the prostate segmentation has something related to this process, or like I didn't understand how the segmentation of the prostate structure help with the disease treatment?
Yeah, I mean, so there are two different things. The prostate segmentation versus the lesion segmentation. Prostate segmentation is more independent. We're actually just using a T2-weighted imaging as an input, and then the segmentation is coming out. The lesion segmentation, it's quite questionable. The one that we presented is based on a T2-weighted imaging because all this annotation is referenced as a T2-weighted imaging. Whereas there will be some differences in the lesion segmentation as a ground truth if you consider all different information together and then combining together, but we don't really have the solution yet.
Okay, thank you. Thank you very much. I think we're just 2 minutes after the hour already. We have to finish. Thank you again for the very nice lecture, and
Okay.
have a good day to everyone. Okay, bye-bye.
Thank you.
All right, thank you.